Hello, my name is StewartGaede. I'm the Chief of Medical Physics at the London Regional Cancer Program. Today we're going to talk about our transitioning from our standard marker block-based stereotactic radiation therapy respiratory motion management program to a surface-guided radiation therapy approach for SABR treatments. I have nothing to disclose. The London Regional Cancer Program is the primary academic regional cancer provider for southwestern Ontario in Canada. You can see on this map of North America where London, Ontario resides. If we zoom up a little bit, you can see that we provide a comprehensive range of cancer care services to approximately 1.5 million people. And here you can see the catchment area for the London Regional Cancer Program. And to put things into perspective, here's London, Ontario right here, and we're about 2 hours east of Detroit, Michigan, and 2 hours west of Toronto, Ontario. We treat approximately 4,500 patients per year with radiation therapy, and we have a large staff composed of 20 radiation oncologists, 13 medical physicists, and 85 radiation therapists. We have 9 linear accelerators, 4 of which are variant TrueBeam machines, one of them having an HD MLC configuration. All 4 have real-time position management capabilities that allow us to do respiratory gating and deep inspiration breath hold treatments on them. We also have 4 variant 2100 IX machines and a tomotherapy machine. 2 of our TrueBeam systems are equipped with the Line RT systems, one of them on our standard TrueBeam MLC configuration and one on our HD MLC configuration. We have 3 gate CT systems. 2 of them are equipped on our Philips wide bore CT simulators, and we also have an installation on our GE Revolution CT scanner, which is an off-site CT research scanner. So we've been treating SABR in the lung at the London Regional Cancer Program now for approximately 10 years. And some of the indications for treating SABR in the lung include inoperable stage 1 non-small cell lung cancer, which is our current standard of care, and also in the oligometastatic disease setting. I've had the pleasure to work with Dr. David Palma on a randomized phase 2 trial comparing SABR to standard of care palliation in this setting called SABR Comet. And we have shown that in the short and long term, significant overall survival benefit with improved quality of life. We are currently accruing patients in a multi-institutional phase 3 trials that include treating up to 10 metastatic sites. Another indication in the neoadjuvant setting where we performed a phase 2 trial that measured the integration of SABR followed by surgery. The 2-year overall survival was 77% and 100% local control rate with no decline in quality of life. This result is important, as you'll see later in the talk. So our radiation dose prescription at the LRCP is based on a risk-adaptive approach that's based on tumor size and location. For T1 tumors that are completely surrounded by lung parenchyma, we offer 54 gray in 3 fractions treated every other day. For tumors that are more than 3 centimeters or that have chest wall contact, we treat 55 gray in 5 fractions treated every other day. And for those tumors that are within 2 centimeters of the mediastinum or brachial plexus, we offer 60 gray in 8 fractions treated every other day as well. Prior to the implementation of Line RT, we had a comprehensive respiratory motion management program at the LRCP that included acquiring a free breathing fast helical CT scan and a 4D CT scan monitored by the Varian Medical Systems respiratory gating for scanners system. If the respiratory motion of the tumor measured with the 4D CT in any direction was less than a centimeter, then we offered free breathing unmonitored radiotherapy on any of our LINACs that used the average 4D CT dataset for treatment planning. If the motion in any direction was more than a centimeter, then we offered patients respiratory gated radiotherapy on a TrueBeam LINAC using the RPM system, which is composed of a single marker block. And for treatment planning, we used a subset average of the 4D CT dataset, which is basically the average of the phases of the 4D CT dataset that lied within the intended gating window. We've always felt that our respiratory motion management program was very robust, but then the pandemic hit. And as we know, COVID-19 virus resulted in closing of many operating rooms around the world, with the aim to protect healthcare workers, to conserve personal protective equipment, and minimize exposure of high-risk patients. For operable stage 1 non-small cell lung cancer patients, we decided to offer SBRT as an upfront treatment and a bridge to surgery 3 to 4 months later. And we were able to do this based on the results of our missile trial that I presented earlier in the talk. This aim was done to reduce the number of visits, and in particular, we decided to offer some patients 34 gray in a single fraction treated with VMAT. And as you know, this large dose of per fraction can place strain on motion management protocols that include respiratory gating as an option. It causes unfeasible treatment times. And it's also unacceptable normal lung exposure if we were to try to treat those particular patients with ungated free breathing radiotherapy. So what about deep inspiration breath hold? Is that an option? Well, in our current program, the use of infrared reflecting marker blocks can only track one point on the patient's surface at a time, and therefore it doesn't differentiate between a true DIBH and other patient moving, including arching your back. Surface-guided radiation systems, however, can directly measure patient chest wall motion and abdominal motion by simultaneously tracking multiple points within a predefined region of interest. We can therefore assess variations in both translational and rotational positions as a result. So a major advantage of SGRT over the use of marker blocks, including deep inspiration breath hold and gating, is the ability to monitor a surface with 6 degrees of freedom as opposed to a single rigid location. And just as an example, before we started implementing DIBH for left-sided breast cancer radiotherapy, we used SGRT as a setup and monitoring tool during a marker block-based DIBH treatment. And this just shows you an example of one patient that received lateral and medial tangents, and for the lateral tangent, here's a representation of the deep inspiration breath hold monitored by the RPM system and the corresponding SGRT monitoring, which shows a good correlation between them. However, for the medial tangent, where the patient struggled a bit in order to hold their breath hold during the RPM, you can see a difference in this case, where the longitudinal and vertical monitoring diverged outside what would have been the standard threshold for this particular case. And this gives us indication that potentially the patient was arching their back or doing some other motion to get the marker block into the intended gating window that did not involve a deep inspiration breath hold. And some of the consequences for this scenario, especially for left-sided breast cancer radiotherapy, could be unintentional increased dose to the heart. So the consequences now for SABRE would be unintentional geographic miss of the target. So this required us updating our respiratory motion management program at the London Regional Cancer Program that took into account the fact that we had a line RT and only 2 of 9 machines, but still needed to facilitate deep inspiration breath hold as an option for our SABRE lung patients when the motion was incredibly high. So our CT simulation protocol was modified in the sense that we replaced our fast helical free breathing CT scan now with the fast helical deep inspiration breath hold CT scan, and then followed by a 4D CT scan. If the motion of the tumor in any direction was less than 5 millimeters, then we just invoked standard free breathing unmonitored radiotherapy on any LINAC and used the average 4D CT dataset for planning. If the motion of tumor now was between 5 millimeters and 15 millimeters, then we still invoked free breathing radiotherapy, but used a wide amplitude gating technique. And this basically means 100% gating window. Basically, we're only using it to gate out larger than intended motion amplitudes and irregularities. And this was using our standard marker block technique. This allows for us to be able to acquire a 4-dimensional cone beam CT to be used for direct image-guided radiation therapy treatments. A line RT in these scenarios are used for setup and monitoring of those patients that are scheduled on our 2 Align RT machines. If the respiratory motion of the tumor in any direction was more than 15 millimeters, then we invoke deep inspiration breath hold using our Align RT system. So with the updated respiratory motion management protocol comes new considerations. First, we had to recognize that patient compliance for DIBH is going to be different for lung SABRE patients than for left-sided breast cancer patients. Their pulmonary function is often poor. We had to recognize that because there's going to be an increase in total treatment time from 7.5 to 34 gray per fraction for SABR versus 2 to 2.65 gray per fraction for left-sided breast cancer patients, multiple breath holds are going to be required. And because of this, we needed to perform a longer training session during the CT simulation, perform multiple practice DIBHs before 15 to 20 second DIBH CT scan, because that single breath hold CT scan will not be indicative of the treatment time when multiple breath holds are required. We also have to take into account the ROI definition may differ for a DIBH patient versus a free breathing SABR patient. The ROI must also include areas where the external contour differs between free breathing and DIBH data sets, to include the lateral sides of the patient and also the lower thorax, where the distance between the ROI and the isocenter is relatively small. So here you can see on the left, this is a patient that's currently free breathing, where we switched on to the DIBH field, and you can see that we're outside the threshold. That tells us that there's a significant difference between the patient's contour, the external surface, when they're in the DIBH versus when they're in a free breathing format, as you can see on the right. We also have to consider that cone beam CT imaging is limited due to the blockage of the camera systems during the CT acquisition. So one solution that we found was to create an ROI that is for monitoring the CBCT acquisition only, that may be further away from the isocenter toward the lower thoracic region. We also have to consider the impact of couch centering for peripheral lesions, and in order to account for couch centering, we needed to create a couch centering field in the record workspace. And then when we capture a reference image on day one, we can use that to draw CBCT monitoring ROI in that particular scenario. So another consideration that we have to think about is the fact that Align RT does not trigger the KV beam currently. That means we're not able to perform 4D cone beam CT for free breathing patients like we have in the past. It also means that we have to manually trigger the KV beam on and off during a DIBH cone beam CT. And this is tricky because how do we know that the patient's in a breath hold position if the cameras are being blocked? So one solution we found is to monitor the diaphragm position during the cone beam CT acquisition and manually beam off when the position changes. So even though the cameras in this particular scenario is being blocked, we can see the cone beam CT acquisition, we can see the diaphragm is still in the same sup-inf location as it was currently, giving us indication that the patient is still in their breath hold. And we can see in real time that if that diaphragm position changed, that the patient is breathing out, and we would manually trigger off the KV beam. So finally, we have to consider the fact that because cameras are typically blocked with the KV imaging arms, it has some impact on our monitoring the treatment. So how can we ensure that the internal target is being treated accurately during a DIBH treatment in this particular scenario? So one way we could invoke is to increase the SAD of the KV imaging arms up to 170 centimeters. That is shown to work. But we could also use MV triggered imaging as well, or CineEPID. So here's a scenario where we're treating a non-small cell lung cancer patient with DIBH treatment. So here you can see that the patient is in their breath hold, and the treatment is being monitored using MV portal imaging. So I'm going to play this movie, and as you can see here's the tumor sitting right on the diaphragm, which is right here. So as you can see, during the VMAT treatment, the MLCs are moving, the gantry is moving around the patient, and for many of the projections you will see the tumor sitting at isocenter. So if we're constantly monitoring and we know that the patient's currently in their breath hold and hasn't changed, you can see the diaphragm position isn't changing. Here's the tumor right here. So some projections, they'll give that patient or the therapist good indication that we are accurately treating the tumor in the correct spot reproducibly during a deep inspiration breath hold monitored by service-guided radiation therapy. So here's an example of a 65-year-old male diagnosed with oligometastatic pleomorphic sarcoma with bilateral lung metastases. one in the left lower lobe, and one in the right lower lobe. The physician wanted to prescribe 34 gray in a single fraction to both lesions treated on the same day. So here's our CT simulation. On the top row is the deep inspiration breath hold scans for both lesions, the 4D CT of both lesions, and then a fusion of both lesions. So on the left is the right lower lobe lesion. You can see sitting on the diaphragm right here, and it's moving approximately 2.5 centimeters in the supimp direction. For the left lower lobe, it's just a small tiny lesion in the left lower lobe sitting right on the diaphragm. It's very difficult to see on the 4D CT, but is in this area and was shown to move about 2 centimeters as well. So in order to facilitate this motion and to treat with such a high dose in a single fraction on the same day, it was decided to treat with DIBH with Align RT. Skipping ahead to the VMAT DIBH treatment delivery, here's the first frame of the Epid cine. Here you can see the tumor sitting here at isocenter, and this is the diaphragm and the first beam shape from that VMAT delivery. As I play the portal imaging, the cine Epid, you can see the MLCs are moving during the treatment. You can see they're starting to rotate around the patient, and the tumor staying stable at isocenter. You can see the leaves coming in and modulating as they're intended. The patient stays in this very stable breath hold throughout the course of the VMAT treatment. We'll let this play out. This patient was able to hold their breath for longer than 40 to 45 seconds at a time, which helps increase the treatment efficiency for sure. And again, you're not going to always see on every image perfect location, but if the patient's still in a stable breath hold according to the monitoring by the SGRT system, by the Align RT, then you know that the patient's still in that location. So what you're going to see now is where the patient finally took their breath, and then they were told when they're ready to come in and take their breath in. And you'll see by the portal image, as soon as they take their breath in and get stable and the beam starts turning on, the tumor's in the same spot. So this gives us good indication that the reproducibility from breath hold to breath hold is intact. The transition from marker block-based SABR treatments to a surface-guided-based SABR treatment has been very positive here at the LRCP. We've treated 12 non-small cell lung cancer patients with DIBH monitored with surface-guided radiation therapy between April 2020 and October 2020. Some of the considerations that need to be addressed before successfully implementing this technique here at the Cancer Center is patient compliance for DIBH is different for lung cancer patients than for left-sided breast cancer patients. The region of interest accounting for DIBH surface changes compared to the free breathing surface has to be accounted for. The blockage during KV acquisition is an important consideration when performing cone beam CT. The couch centering is also something that needs to be addressed as well. And also the inability of Align RT to trigger the KV imaging beam required careful attention during CBCT acquisition to ensure that patients are holding their breath during the cone beam CT. We've also were concerned about not being able to trigger the KV beam during treatment, so we used a lot of MV Cine Epid to ensure that our treatment has been accurate as well. So in conclusion, the transition from single marker block monitoring to surface-based monitoring of lung lesions is feasible, and deep inspiration breath hold using surface-guided radiation therapy is also feasible, but requires accurate 3D setup imaging and intrafraction monitoring to ensure accurate treatment delivery. And I'd like to acknowledge the various radiation therapists, medical physicists, and radiation oncologists involved in the successful clinical implementation of surface guidance for lung cancer SABR treatments, and I'd be happy to take any questions. Thank you.